Welcome to our NYU Langone Orthopedic webinar series, Optimizing the Outcomes in Hip Preservation. Thank you for joining us. My name is Eric and I will be the facilitator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. On the bottom of your screen, you will see the Q&A window. To send a question, click in the text box and type your text. When finished, click the send button or press enter. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed throughout and at the end of the presentation. We are joined today by our course director, Dr. Pablo Castañeda, and our presenters, Drs. Roy Davidovich, Guillaume Gonzalez-Lomas, Jody Litrenta, and Thomas Yelm. At this time, I would like to turn the microphone over to Dr. Castañeda to begin the presentation.
Thank you very much, Eric. Good evening, everyone, and welcome to tonight's webinar in the NYU Langone Orthopedic webinar series, focusing tonight on optimizing the outcomes in hip preservation. I want to give a special thanks to Dr. Mehul Shah, Dr. Michael Alea, and Dr. Joe Zuckerman for allowing us the opportunity to present tonight. And a special thank you to all of the faculty who have put considerable time into preparing this session. I hope that we will have a very interactive webinar. We have actually built in plenty of time for Q&A to hear from people on the other side, as we know that hip preservation is a very wide-ranging field, as you can see embodied by our diverse faculty tonight. We have in alphabetical order Dr. Roy Davidovich, Dr. Guillaume Gonzalez-Lomas, Dr. Jody Litrenta, and Dr. Tom Yum, ranging from pediatric orthopedic surgery to adult reconstructive and sports medicine. So over the next 90 minutes or so, we will define the spectrum of pathology that makes up the conditions that can be treated through hip preservation surgery, outlining dysplasia, and then moving on to the other end of the spectrum, talking about FAI, femoral acetabular impingement, discussing both arthroscopic and open procedures, concluding on the limits of hip preservation. So I'll start with dysplasia, a condition that is so prevalent that not a day goes by, literally, that I don't see someone with hip dysplasia. And this fantastic study from Denmark used the National Osteoarthritis Registry to determine just how prevalent hip dysplasia is. And they used 4 standard radiographic dysplasia measures. The most commonly used one is the lateral center edge angle described by Viberg. They also used acetabular inclination angle. They used the extrusion index and the acetabular depth ratio. And when they measured all 4 of these things on this cohort of patients, what they found is that 1 in 10 people had signs of radiographic dysplasia. So think of how common that is. 1 in 10 people have one of these signs of hip dysplasia. But if you only use center edge angle, which is the most commonly used measure, it's at least 3%, which is still very high, meaning that 1 in 30 people will have radiographic hip dysplasia. So it's an incredibly common condition, and we know that it can lead to significant disability. From a practical standpoint, the most useful measure, as I've mentioned, at least for me, and I think most of the faculty use this, but we'll discuss this as we get into the nuances, is the lateral center edge angle. I don't only measure lateral, I actually measure the medial as well, as that gives me the so-called acetabular arc, which is a measure of the load-bearing area of the joint. And when we talk about hip preservation, procedures are designed to increase the joint surface contact area. The other measurements I use are tonus roof angle, which is an indication of the load-bearing area's inclination. Sharps angle is also the acetabular inclination and determines acetabular tilt. And the extrusion index as a quantitative measure of coverage of the femoral head. I also look at this, possible crossover signs, which can indicate retroversion to determine if hips are lacking anteriorly or posteriorly, but ultimately we almost always get cross-sectional imaging, whether it's MRI or CT. And again, I won't get into the nuances of this at this time, as I'm just introducing the concept for us. So in the classic description of hip dysplasia by Bob Stalter from Toronto, he said that all dysplastic hips have increased femoral anteversion, a shallow acetabulum, and capsular laxity. But you must remember that X-rays are two-dimensional representations of a three-dimensional structure. And with this advanced imaging, we can do a much better job of understanding the complex nature. We now know that combined version plays a much bigger role, and not every hip behaves in the same way. But this is a classic example of what I see very frequently, a 19-year-old with high-grade dysplasia. You can see a negative center edge angle on the hip on the left, with a very shallow acetabulum, a very steep tonus angle, and more than 50% extrusion of the femoral head. So by focusing on these measures and performing a PAO, I believe we have significantly increased the load-bearing surface of the joint. We did relieve the pain, and hopefully we've bought her many years before she needs a hip replacement. Although she may now actually be on the other end of the spectrum, and you can see if you compare the right hip to the left hip now, she may have been taken a little too far, and Dr. Yum will now tell us if this patient's going to have impingement from the overzealous correction that I achieved. So with that, I'll hand it over to the second part of this introduction to Dr. Tom Yum.
Thank you. Again, thanks, Dr. Castaneda, for planning this event. I'm going to talk about femoral acetabular impingement. So on the other spectrum of the socket, where we're talking about now over coverage, not a shallow coverage. So there's a lot of evolution of thought in this field in the last 30, 40 years. And in the 80s, I would say anything in the hip, especially in athletes, was considered tendonitis, bursitis, arthritis. Young patients were told that they had arthritis, needed a hip replacement. Somewhere in the 2000s, our imaging and our science got better, and we identified labral tears in the hip as a source of pain. And early results were decent, but they got better because we started looking for structural sources of these labral tears. And one of the most common, aside from dysplasia, is also femoral acetabular impingement, also including laxity and trauma. So FAI is an abutment conflict between the bone of the femur, the ball, and the socket. And this aberrant morphology leads to abnormal contact in the hip joint, causing symptoms. And so this is an animation. Please press play. Animation showing an exaggerated acetabular rim with an exaggerated femoral neck. We call that pincer on the acetabular side and cam on the femoral neck side. Next slide. Got it there. So cam FAI is an abnormal femoral head with increased radius. We tend to see it more in young and active males. This increased radius rubs against the acetabulum, creating inflammation and damage. And it not only disrupts the labrum, but also starts to wear away the articular cartilage. Pincer FAI is more typical in a middle-aged woman. It's an acetabular abnormality between the rim and the femoral neck. And that rim is typically enlarged with associated labral damage. So you know that most of us don't have pure pincer or pure cam impingement. The majority have a mixed type impingement. Please press play. So again, this is an animation showing an exaggerated cam lesion. You see prominence of the head-neck head-neck junction and how that disrupts the labrum. To the right, you see a prominent acetabular rim, and you see how that can lead to impingement. And you can see on the left, the cam impingement typically disrupts the junction of the labrum and the articular cartilage, whereas on the pincer, you see more just linear contact or crushing of the labrum itself, not so much the articular cartilage. Next slide. I got it. So these morphologic abnormalities lead to abnormal contact, tearing of the labrum, avulsion of the cartilage, and eventual arthritis, and we're trying to avoid hip replacement in these younger patients. So arthroscopically, this is an example of a normal chondrolabral junction. You can see the labrum and the articular cartilage is somewhat contiguous. That's my probe, right, kind of at the junction. And it's important because, press play here, when you have damage to the chondrolabral junction, it's not quite like a shoulder where you see complete separation of the labrum from the glenoid. Here you see that the whole continuity of the labrum where it meets with the articular cartilage is delaminated. And what that eventually, next slide and next video, please. If you can play that video, what that delamination or pita lesion eventually becomes is a full thickness cartilage lesion. And if you imagine this in a young person, when you go in for a hip arthroscopy, it's a very unsettling sight because this is what eventually leads to a hip replacement. You can stop here. Next slide. This is an example of a pincer impingement. You don't quite have the same sort of cartilage delamination, but you can see erythema and crushing of the labrum. You can stop that. We'll go next slide. And that can also lead to some cartilage delamination. You can skip this one, please. Okay, so this became distorted a bit, but the normal femoral head neck junction would look like that. We call this a pistol grip deformity or cam lesion because you can see the similar shape of a pistol grip. Arthroscopically, I can identify the cam lesion. We can burr it down, and we can do a dynamic exam, making sure that doesn't abut on the labrum. This is what it looks like pre-osteoplasty, and this is what it'll look like post-osteoplasty. As far as acetabular retroversion, what we're looking for FAI is focal proximal retroversion. We're not looking at a global retroversion, that's more dysplasia. But here we're seeing a focal crossover sign proximally. You need a good AP pelvis to see this. And you can even mark this out on your C-arm fluoroscopy where you can see the crossover sign. And after you take a burr and resect that down, you can see the resection of the crossover intraoperatively at the time of hip arthroscopy. And this is some pre and post-op x-ray. So that's just an introduction to FAI. If you can go to my next talk. My next talk here, as we go from our introduction, is going to look at if arthroscopic approaches are indicated for hip dysplasia and when. So, as Dr. Castaneda described, the fundamentals of dysplasia, you have obliquity of the weight-bearing zone, you have acetabular version issues, the labrum is hypertrophied, mechanically it leads to static overload of the rim, local stress concentration leading to labral hypertrophy and tears, and dynamic instability from the shear forces. So acetabular deficiency oftentimes leads to labral damage, and we know that PAO or pelvic osteotomy is a very effective surgery in relieving symptoms, but it's complex open surgery, so it's very tempting for us arthroscopic surgeons to treat the labrum. And we know there's good long-term results with PAOs, 80% good outcomes in this study at a mean of 9 years, low surgical complication rates, but there are some predictors of poor outcome, age greater than 35, fair or poor pre-op joint congruity, decreased joint space width. This is a well-quoted study about why arthroscopic surgery for the hip for dysplasia may not be a great idea. Parvizi looked at 34 patients. 24 of these patients, while they had some symptomatic improvement at 6 weeks, by 3.5 years, they failed. Accelerated arthritis at 14 patients, migration of the femoral head in 13, and 16 of these patients needed further surgery, 6 PAOs, 7 FAI osteoplasties, and 3 total hip replacements. So not very good. And we've learned a lot from case studies as far as arthroscopic surgery. This is a 42-year-old woman, right hip pain, had a labral tear, mild dysplasia, center edge angle 22 degrees, tertial angle 11 degrees. They stated they removed less than 1 millimeter of the rim. They did a labral repair, debrided the ligamentum, and they did a capsulotomy, which is routine in hip arthroscopy, but they did not repair. And so you can see at 3 months and 1 year, accelerated arthritis and deformity of the head. And their conclusion is that they recommend capsular repair and preservation of the labrum and ligamentum teres. This is another study of Dean Matsuda, iatrogenic dislocation following a hip impingement. So I want you to notice the center of the femoral head. You can see both walls here medial to that femoral head, indicating perhaps there's a little bit of retroverted dysplasia in this patient. But in the report, they reduced the center edge angle from 31 to 18 degrees, and that's only from taking about 4 to 7 millimeters of the rim. Capsule was not repaired, and this patient led to a dislocation after hip arthroscopy. This is another case, arthroscopic debridement. They removed the pincer impingement, over-resected. You can see what happened here, led to a hip replacement, some pearls. The center edge angle is 23 degrees, but the next shaft angle is greater than 140 degrees. So it's another parameter you probably need to look at. And instead of debriding, you really have to repair the labrum. You really cannot resect the rim on these patients, and you have to consider a capsular plication. So what are our results more in the modern literature compared to Parvizi's initial studies? What we learned from these case studies is that if you have a mild dysplastic center edge angle 18 to 25 degrees, this is a 2-year study. You do an interportal capsulotomy. You don't detach the labrum. You minimally trim the rim. You do an anatomic labral fixation, and you close the capsule, and you get pretty decent results, 17 or 77%, good, excellent results. Only 2 patients required revisions. And you take that to 5 years, and they were able to follow up 21 to 25 hips, mean age 23 years, lateral center edge angle 22 degrees, tonus angle is 6.9, and they had good results. 4 hips required a second scope, but none of them required total hip replacement. We also know that femoral version is important. What happens in these patients with femoral version, increased femoral anaversion and borderline dysplasia? Study looked at mild dysplastics with labral tears who underwent capsular closure and had femoral anaversion greater than 20 degrees. They had improvements after hip arthroscopy compared to a normal cohort, but at 4 secondary surgical procedures, or 33% compared to only 1 or 4.2% in the normal cohort. So a very good idea to figure out your femoral version ahead of time. And then this is a very recent study in arthroscopy, a systematic review looking at borderline hip dysplasia. And they found significant increases in modified hip Harris scores, MCID of about 80 to 85%, with only a 1% complication rate. And they found that in 11 studies, all patients underwent capsular plication. So risk factors, age over 35 or 42 and greater than 20 degrees of femoral anaversion in this borderline hip dysplasia group for hip arthroscopy. So arthroscopy can be very beneficial. If it's performed, you have to preserve the labrum, avoid any debridement, consider base refixation stitches to maintain the suction field of a hypertrophied labrum. Capsule needs to be repaired. Don't touch the psoas. It's an anterior dynamic stabilizer of the hip. And be aware that there are patients with FAI on top of dysplasia. You can have a cam lesion in a patient with a shallow socket. So it's okay to consider arthroscopy and PAO in certain patients. Please start video. Please start video. So this is a video of a hip labral repair in a patient with some mild dysplasia. We did a interportal capsulotomy. We're getting our cannulas in here. And that's our probe looking at the labral tear. You see a hypertrophied labrum. And so I'm going to fast forward a little bit. But once we identify the rim, we actually take some of the subspine. So we don't trim the rim right where the labrum is, but we take some of the subspine because that's not going to affect the lateral center edge angle. I use a base refixation stitch, which is essentially a vertical mattress stitch to take advantage of the thick labrum that we have here. And we use knotless anchors to put this together. And the idea here is to recreate a suction seal, all right? So we're putting sequential anchors in a base refixation manner. I think this is our third anchor. I'm going to fast forward a bit. We do our chondroplasty, and then in the front, you notice I did a simple stitch. I didn't do a vertical mattress because that labrum is thinner in that area. So you really have to base your anatomy or your surgical tools based on your anatomy. But what I want to show you is at the end, when we release the traction, if you do a proper labral repair, you get a nice suction seal. Stop video, go to the next slide. So you really have to consider the capsule. The hip capsule is comprised of some of the strongest ligaments in the body, provides proprioception and structural support. This study showed that anytime we do an interportal capsulotomy, which is a standard capsulotomy between your two portals for hip arthroscopy, you're cutting through the iliofemoral ligament. And the iliofemoral ligament in cadaver studies, when you release it, it shows a significantly increased external rotation of the hip, which eventually will lead to instability. And you combine that with a dysplastic hip, and you can see some of the devastating consequences if you don't repair the capsule. What I look for when I pull traction is supraphysiologic distraction. If the amount of distraction with a pull is greater than 2-3 centimeters, I'm worried about capsular laxity. And those are cases where we perform an interportal capsulotomy and we make sure to close the capsule. Please play video. So this is an example of a capsular repair in a patient with hip dysplasia. You can see the labral repair was already done. You can see a nice thick hypertrophied labrum. And we're trying to create a nice vertical height for the labrum to create a suction seal. And we use a suture lasso to pass 2 sets of sutures through the capsule. The video, I'm sorry, is a little bit blurry, it's looking like. But you can see the 2 sets of sutures, and those are tied down to close the capsule. You can stop video. We'll go to the next slide. All right, so I also use this figure of 8 technique where I pass 2 strands of the same suture in a figure of 8 configuration to get my capsule closed, and it's a good closure when you don't see the rim or the labrum. So patients with a lateral center edge angle of 20 to 25 degrees is really a difficult cohort to treat. You send these patients to a PAO surgeon, and they'll tell you it's not enough dysplasia to warrant a PAO. And they go to an arthroscopic surgeon, and we've all had some poor results with dysplasia, and we'll tell them that results are good but not excellent. But the literature does support hip arthroscopy with rim and psoas preservation, labral repair, and capsular application in this patient population. And if the operation fails, we can consider PAO. This study looked at PAOs after and hip arthroscopy and without hip arthroscopy. And both groups had similar improvement in symptoms, but the caveat here was that total hip conversion rate was higher in the scope group. This systematic review, I'm just going to read the bold. While the data supports that patients with frank dysplasia are best treated with PAO, there's no such preferred treatment for patients with borderline hip dysplasia who have a wide spectrum of instability. Selective use of arthroscopic labral and capsular treatment alone may provide good results in carefully chosen patients with borderline hip dysplasia, while some may end up requiring a bony realignment procedure, kind of what we discussed in this talk. So if it's really bad dysplasia, do a PAO. If it's mild or borderline, do an arthroscopic technique with the techniques that we described, and consider combining a PAO with an arthroscopy. If you have a cam lesion with a shallow socket, do both. Stage it, do it concomitantly. There's plenty of studies I've listed here that show that doing both can have very good results. And with that, I'm going to just show a quick last case. This is my own case. I had a 33-year-old woman who had left hip pain. She had dysplasia and a labral tear. So I thought I did the right thing. I would fix the labrum, and I planned to stage PAO with a surgeon at NYU. And what we saw at the time of surgery was some grade 3 congemination of the femoral head. So in retrospect, I should have probably told the PAO surgeon that this may not be a good candidate. She was in her early 30s. The PAO went fine, but at 5 months, you can see degeneration of the joint. She went on to a hip replacement. So point being, you can do everything that your science tells you to do, and sometimes it doesn't work out. Thank you.
All right. Thanks, Dr. Hume, for that. And now Dr. Latrenta is going to tell us about the open side and when you should add a pelvic procedure and do the PAO.
Thanks very much for that introduction, and I'll just try to add on to that by saying there's a couple of scenarios where we can consider adding a pelvic procedure, and one is when we're thinking really about the pediatric population and we say let's do it after the reduction of the dislocated hip, or the second scenario, which is really what was talked about in the last talk, which is more treating that adolescent with acetabular dysplasia. So first, when we're talking about after the reduction of the dislocated hip, well, here's an example of a baby girl that was about 7 months old that had you can see that the right hip is dislocated in the x-ray. You can see that there's no appearance of the ossific nuclei on either side, but you can see that Shenton's line is intact on the left and you have a dislocation on the right. And based on this child's young age, this patient was brought to the OR for a closed reduction, which was achieved. And at the time of the closed reduction, you can see that I did an arthrogram here, which is a way to better, not always necessarily needed, but is a way to helpfully to help you define the contours of the femoral neck and the acetabulum. And one predictive reason to do this, which is the title of my talk, When Do You Add a Pelvic Procedure, is the realization that when you do a closed reduction in hip dysplasia, you very often in that population, at least 50% of the time, are going to need to go back at a later stage and add a pelvic osteotomy so that you can because that child is not going to get regular acetabular development without you doing something to sort of catch them up. So one thing that you can do is use the arthrogram to look at actually the amount of coverage of the femoral head that you have here. You can see this line is drawn at the lateral border of the visible bony acetabulum. You can see the arrow pointing at the edge of the labrum. So we know there's a cartilaginous portion of the acetabulum that you can't actually see. But when we look at this study, it really interestingly found that if you just drew that lateral border of the bony acetabulum in the young child, that this could be predictive of who is actually going to go on to need a pelvic osteotomy. So when you looked at a group of 139 hips that actually were a little bit, I think, older at closed reduction, this was done at an average age of 14 months and using very standard threshold for what we accept in terms of acetabular dysplasia measurements, we found that if that femoral head was covered less than 30% at the time of the closed reduction, that was predictive that later on you were going to need to go on and do that pelvic osteotomy. In other words, it's not enough to just do the closed reduction and put the baby in in a spica cast, which is how we maintain that reduction after achieving it. So what if you have dislocated hips that you don't treat with closed reduction, but you treat them with open reduction? So it's an open procedure to take that dislocated femoral head and place both of them in the acetabulum. This is bilateral dislocation. You can see it's a little bit more obvious on the right, but certainly on the left, you can see that acetabulum is not normal, and the hip itself is lateralized. So this is a child that underwent open reductions at around the age of 2. And how do we know if we should add a pelvic procedure or if we will need to add one later on, as I was just talking about in the case of closed reduction? So this is a analysis that looked at a number of studies with children that underwent open reduction between 1 and 6 years old. And what they found was half of the patients that were treated with open reduction alone later went on to need a pelvic osteotomy for residual acetabular dysplasia. One of our most sort of feared complications in treating babies with dislocated hips is avascular necrosis. And it's very interesting that the lowest rate of AVN was seen in patients that just had the open reduction rather than in patients with open reduction and pelvic osteotomies. But that's a little bit, difficult to sort of say, try to avoid the pelvic osteotomy in that case, because you can see that many patients did go on to need it anyway. And the truth is that very many dysplastic hips may need to be stabilized with a pelvic osteotomy at the time of the open reduction, and they may be hips that are a little bit more likely to go on to AVN anyway. So what are the types of pelvic osteotomies after an open reduction? You can do most commonly a Salter or a Pemberton, and I think it really comes down to personal preference, but there certainly are benefits to either one. The Salter is an osteotomy that's made above the hip joint through the acetabulum, and you're actually able to take and manipulate that shallow acetabulum, that shallow piece of the pelvis, and bring it over the femoral head. It does need to be fixed. That's usually fixed with some K-wires and some graft to hold it into place. In contrast, you can see in the diagram here where the Pemberton osteotomy is, and this is angled a little bit differently. It's done in a way, we talked a lot in the last talk about where the dysplasia is. We saw an example of maybe some retroverted hip dysplasia. Here we know that the dysplastic portion of the acetabulum tends to be anterolaterally, and the way that the cut is done in the Pemberton and the way that the bone is moved in the Salter osteotomy are done so that they can better cover the femoral head. So this is an example of the case that I just showed. This was the 2-year-old patient that did have staged open reductions. And this is a Pemberton osteotomy that's done on the left, where the curved osteotome is introduced in an anterolateral direction into the triradiate cartilage, and then it hinges on the triradiate cartilage to improve that lateral coverage over the femoral head, and it's held in place not with fixation, but you can see like a very large bone graft. So what are the risks if we treat a patient who has acetabular dysplasia with this technique of trying to actually create coverage? Is there any problem down the line with that you might end up needing to address with a hip arthroscopy? In other words, it's the title of this paper: how often does femoral acetabular impingement occur after pelvic osteotomy? So Dr. Castaneda participated in this paper, as you can see, and noted that when you looked at types of osteotomies, whether it was a Pemberton or a Salter, you could have findings of SAI later on. These patients were all followed for at least 10 years, and they defined impingement by either that lateral center edge angle combined with having some pain with flexion greater than 90 degrees. And it was found that patients that needed to have higher degrees of correction for dysplasia And if you had a Pemberton osteotomy, which is more of a volume reducing osteotomy, you are a little bit more likely to have impingement than if a Salter osteotomy was used. So let's say you have a developmental dysplasia of the hip that's either treated with an open reduction or perhaps not treated, but found in the form of this acetabular dysplasia later on. And you can see in this particular X-ray, the right hip looks dysplastic, but the left hip really has, very significant dysplasia. And in addition, you can actually see some subluxation of the left hip as well. So what can we do for these patients? And I'll go through this kind of quickly because I think it was just very well summarized before, how we look at borderline versus frank dysplasia. So having the hip that I just showed, which is undercovered, and not only that, is subluxated, is frank dysplasia, whereas the borderline patient is someone who tends to fall into this 18 to 24 degrees of coverage and may actually be managed very well with arthroscopic techniques that do include capsular plication. So when in these hips do we need to think a little bit more about adding a pelvic procedure? Obviously, I've showed you the baby with the dislocated hip, but what about in an older child or a young adult that has acetabular dysplasia? And one is, we've talked about treating it with a hip scope, but the second thing is, when do you consider doing a pelvic procedure in addition to doing your hip scope? So this, again, was talked about a bit, but we know that if you do a hip scope for borderline dysplasia, that you may actually avoid PAO, and that's certainly a great thing. But you may be in this sweet spot where you have a borderline dysplasia, which doesn't seem like it's quite enough for a PAO, but may not do as well with arthroscopic techniques either. Another thing to consider that can sometimes be a benefit for doing a hip scope in this population is going in and identifying whether there's cartilage damage there. So if you have sort of an intermediate age patient and you're considering doing a staged procedure where you do a hip scope and do I think this person is going to be a good candidate for a PAO or not, this may actually change your plan and how you counsel the patient if you notice more cartilage damage perhaps than you were expecting. And finally, another reason to consider hip scope while you, as a part of, as a additional procedure, even when you do know that you need to do a pelvic osteotomy, is that it really gives you a chance to address any sort of intra-articular pathology. So when you do this pelvic osteotomy, you don't necessarily see into the hip joint unless you do an arthrotomy. So that's a nice benefit of doing hip scope. You now don't have to do an arthrotomy. A final thing is I mentioned the fact that you can get SAI in the pediatric population, both after the Pemberton and the Salter. Certainly, if you reorient using a PAO and you increase areas of coverage, but you might have a little bit of cam impingement, you might actually create increased areas of loading, and that may be something that you might be able to address at the time of doing that procedure. So I would just like to point out that when we're talking about the young baby dislocated hip, it's very often that you are going to need a staged pelvic procedure for the purposes of acetabular dysplasia, and that occurs both after open and closed reduction. And then secondly, that certainly doing a PAO is going to be the best option in an older child with frank dysplasia, but you may even be considering it in certain borderline patients.
Thank you very much, Jody. That was an excellent overview. Is that you climbing Mount Everest?
No, that's Rainier, but yeah, very happy someone took that picture.
So we're a little bit over time, but we do have some time for questions now. We had built in a Q&A for the dysplasia section, and then after that, we're going to talk a little bit about FAI. We have a few questions from the audience, which I think may be answered by the next speakers. But while I have Dr. Latrenta and Dr. Yum, who just gave their talks on dysplasia, there is one question about Shenton's line, which is a very commonly used measure when people are describing X-rays. And I have found it to be of little use in the pediatric population. But for me, it's a good marker of the degree of subluxation and of dysplasia. So to both of you, Dr. Latrenta and Dr. Yum, maybe you can just tell us if you use the Shenton's line at all in your decision making.
I think it's sort of a little bit more of a binary thing. If Shenton's line is broken, you can, I think it really just shows like the amount of dysplasia, or really that I'm thinking of that case I showed where you actually see, subluxation, and certainly in the baby hip where maybe you're looking at an X-ray and you can't see the ossific nuclei. It's really just showing me that this is a hip that has some degree of subluxation or probably dislocation.
Yeah, I don't really see patients with a break in Shenton's line. I think it would be, they don't really. I don't think they would come into the office for the most part in my practice.
Yeah, I think it's. I'll tell you my perspective on this, because I do think there was a study from the Anchor Group looking at Shenton's line. Again, more as a measure of subluxation. And I think that the key to doing any kind of pelvic procedure is you do have to have a concentric reduction. If you can achieve that through motion, then I think you can do a PAO. But when I see a broken Shenton's line in the setting of high-grade dysplasia, I will counsel the patient that the likelihood of success is lower, especially if there is a high-grade labral tear at the same time. Okay, well, if we don't have any other questions right now, we'll move into the next section, and I'm very pleased to see we do have over 110 people logged in. And again, I would encourage you all to submit any questions you may have or comments in that little box you see on the lower left of the screen that says Q&A. We'll try to get to these questions. There are a couple of other questions, but I think that they may get answered as we move through the next block of talks. And if we don't, then we'll certainly get to those questions at the end. So our next presenter, we're going to switch gears and talk about FAI. And Dr. Guillem Gonzalez-Lomas is going to talk to us about so-called primary FAI and the arthroscopic treatment of it. Guillem, take it away.
Sure. Okay, great. Thanks a lot, Pablo. And Tom and Jody, fantastic talks. I learned a lot. So let's get right into it. So we're talking primary FAI. And we're all familiar with the concept of impingement that Tom illustrated, but really not every FAI is the same, and it's important to understand that. This is a patient that we're probably familiar with, mixed cam pincer. They've got a synovial herniation pit, elite athlete. Here's a patient that we kind of alluded to in the earlier talks. So they do have a cam, but they're also dysplastic. How do we manage them? Here's a patient who's a little bit older. So they're 55. They don't have a lot of arthritis. They have FAI. Do we just give them palliative treatment until, they're ready for their hip replacement, or does arthroscopy play a role? And underlying all of this is the concept of morphology versus impingement. Even the term FAI is tricky because it has the term impingement within it. But FAI is often a radiographic diagnosis, and we know, for example, that up to 20% of the population has FAI, and they're completely asymptomatic. So we really have to make sure that we're correlating the anatomy and the morphology with the symptoms. All right, so how to work these patients up? Typically they're going to come to the office presenting with this C-sign distribution pain, very often in the anterior groin, a little bit in the posterior area as well. The classic impingement test is flexion and internal rotation, and really the vast majority of patients will have a positive test with this. But there are cases of posterior impingement, and so you can elicit the pain here with extension and external rotation, as well as with a Faber test. I think it's very critical with any patient that you're thinking FAI in, because there is such a large cohort of asymptomatic FAI patients. It's important to rule out other causes of pain around the hip. So you're going to want to do a straight leg raise, a Lasag's sign, rule out any radiculopathy, piriformis test. You can have more peripheral sciatic nerve impingement. And then obviously greater trochanteric bursitis can oftentimes mimic that posterior pain as well. It's so important to assess that with palpation and an Ober's test. And this is because there is a cohort of patients that presents with atypical hip pain. So this is a paper by our very own Dr. Hume, who looked at this presentation. So rather than just anterior groin pain, pain posterior and laterally, and they found that up to 30% of patients presented this way. The good news was that they all did very well postoperatively, even if they did have pain that was not specifically in the anterior groin. What about x-rays? So again, really critical in all these patients to rule out any possible pretenders. Stress fractures, very common in a young athletic population. Get an MRI to look at that. If something about the diagnostic workup does not smell right, their injection was negative, their diagnostic injection was negative, they just don't have an exam that really fits FAI. Get a lumbar spine MRI, rule out stenosis. And arthritis is a big one. We talked about this in dysplastic patients, but this certainly is sometimes prevalent in older patients who are still, younger than you think, so 30s and 40s. Patients with arthritis tend to not do as well with hip arthroscopy, and you have to really be honest with this. Subchondral cysts, for me, are a big red flag. I don't scope those patients. You're going to want to get good x-rays. So for me, I get at least 4 views, so standing or sitting AP pelvis. There's a little bit of discussion about whether standing or sitting APs really demonstrate that anterior overcoverage of the pelvis. With standing, you do get a little bit of increased posterior tilt of the pelvis and a slight uncovering of the anterosuperior rim of the acetabulum. So they may report potentially pincer impingement a little bit more accurately. But certainly either one is appropriate. Frog leg or cross table lateral to look at that anterior head neck junction. Your workhorse that's done at 45 degrees is going to see your head neck junction in profile, that anterior superior aspect of it, and then false profile to look at the anterior aspect of the acetabulum. You want a good AP, so you want the tip of the coccyx to be 1 to 2 centimeters from the symphysis and centered over it. Again, here's your done lateral, so you're going to see most of your cam deformities in profile here, and we're looking for that alpha angle to be greater than 55 degrees. This is a nice view to get intraoperatively as well as you're rotating the hip, but it really helps to kind of identify how much you've taken out. I think there's some new additions to the radiographic armamentarium that I found very useful. One are the radial cuts on MRI, where you're cutting that labrum and that acetabulum in a perpendicular fashion along the clock face. I think it really showcases, as you can see here, the labrum tear, and it allows you to not get those tangential cuts that you sometimes get with the sagittal or the axial views. And then 3D reconstructions have started becoming more ubiquitous using MRI. So this is nice because it obviates the use for CT, which of course requires radiation. I think the next step here is to actually, there is software already that exists for this, but it's actually to assess the bony impingement preoperatively. So there are a few companies working on that, and that's an exciting move in the right direction. Dr. Hume alluded to subspine impingement, and I think this is an important concept to understand. Again, important to really differentiate between morphology and impingement. So I think it's generally accepted that there are three major types of subspines, and they basically just relate to how far below the acetabular rim they hang. And so that anterior inferior iliac spine can contact the head neck junction of the femur and cause impingement in its own right. Some recent papers have found actually significant subspine impingement even in type 1 cases. So really you want to assess this intraoperatively. That's the best way to do it rather than just relying on static imaging. What about injection? And so, for me, these form a very important part of my diagnostic protocol. A few studies looking at these, including some systematic reviews. And I think the take home for me with injections is they will not predict your outcome. However, a negative or non-response to an injection is a very good indicator that arthroscopy may not benefit that patient. So I always get concerned when a patient doesn't respond at all. And I'm really looking at the portion of the injection with the local anesthetic. Usually use ropivacaine. You can use lidocaine as well. And if they have no response at all, then my ears perk up and I start to look for other possible causes of hip pain. Okay, getting into the arthroscopy part of it, I won't go into too much detail about the setup, but traditionally we use these very well padded posts, and we had to talk to patients about potential transient numbness in their feet and even in the perineal area. And this is, an absolutely fine way to do it. We generally want to keep the traction down to below an hour and a half, certainly below 2 hours. There are some new devices, some new mats that actually obviate the need for a post. So that's actually exciting because the post oftentimes gets in the way of a full range of motion of the hip. You have to take it out mid-case. The pad is basically a cushion that has some adhesive properties to it. So patient lies down and you can actually get some very adequate hip distraction for entry. And then once you've actually penetrated the capsule, typically you get your air arthrogram, and then you're off to the races. I think it's very important. Tom did a nice overview of the hip arthroscopy basics, but it's important to understand that there are limits to what you should do. So rim trimming is one of those. There's a nice paper out of Rush, which basically showed an increase in rim pressures pretty much at around the 4 to 6 millimeter mark. So regardless of how deep that hip is, regardless of how large the center edge angle is, once you resect more than 6 millimeters, you're getting into a potential danger zone. And so this may be a hip that still, relatively has a large center edge angle, but for that patient will probably do enough. And what you don't want to do is create iatrogenic arthritis, because that's what can happen. I think this is especially important in those patients with coxa profunda and protrusio. Here's a study that showed that the 10-year survivorship for protrusio was only 51%. And obviously the theory here is potentially that you're resecting more than you need. Here's a patient with not quite protrusio, but they've got a pretty deep hip. And, here what we do is we basically do the opposite of a dysplastic hip. So in this case, we actually try to take, some more. These are patients where oftentimes that labrum has been crushed. So they're patients where I'm going to do circumferential sutures just because sometimes it doesn't have the integrity to hold a vertical mattress. And then we put we do our repair, we put our anchors in, and here's the post-op. So again, did we take a little bit too much off? We stopped at about 5 millimeters, and hopefully that isn't too much. On the other side of the spectrum, we discussed this a little bit, hip dysplasia. I'll just go over this quickly. Here's a patient already maybe on the verge of arthritis, but then 2 years after really not touching that rim too much, but you see the significant advance in arthritis. So always on the lookout for these patients. This is from the x-ray at the beginning of the talk. So this patient has some CAM, but they're clearly dysplastic. So what do we do? And this is where it can be very helpful to, work with other colleagues who do PAOs. So this is a case that actually Pablo and I did together. So the patient had a labrum tear. We fixed that and then did a PAO, and they did great. CAM is on the other side. So how much do we resect here? And obviously, it's another Goldilocks issue. Although in this side, really, I'll say it at the beginning and I'll say it at the end. If you're going to err, you want to err on the side of under resection. You can always take more out. You can't add more bone back. So here's a case of under resection. Here's a case of over resection. You see that big apple bite right at that head and neck junction. And really what you want to do is not resect more than 5% of the diameter of the femoral head on the done view, because that predicts failure. A nice study here done by Ben Dome that looked at patients with over resection, and they found that 30% of them converted to total hips after 3 years. So really important to be parsimonious with your CAM resection. Tom discussed capsule closure as well. And what I'll say about this is the capsule does remain closed. Sometimes we wonder if, the second the patient enters the PACU, if that capsule is going to just pop open. But there's a few studies showing that over 90% of capsules that are closed remain closed. And the literature is a little bit divided. Overall, there are several studies showing that there is really not much of a difference. But again, this is in all comers, not necessarily those dysplastics or those patients with ligamentous laxity. And then also in athletes, it seems like it can matter. So this is a study looking at that and found that 90% of the athletes who had capsular closure versus 75% of those who didn't return to their sport. I typically will close the capsule unless it's in a patient who, has coxa profunda, big pincer, or perhaps a little bit older as well. And that gets into the concept of age. So, a few studies, and this was one of the ones that showed up on JBJS, basically made us a little, sobered our perspective on doing hip arthroscopy in older patients. But it is important to note that all of the patients, especially in this study, all of the patients did improve from their baseline preoperative scores. It's just that the outcomes were not as good for patients over 45, and they were decidedly less good for women over 45, but they all still did well. So I think that is an important take home. That said, those are patients that you really want to have kind of a low threshold for perhaps doing palliative treatment and not going in for the scope. So our poor bagel baker here, he makes bagels, but he also has FAI. You can see he's got labrum tear, a little bit of that delamination of cartilage. The labrum is maybe not the most robust thing, and we could get into whether labral reconstruction would be reasonable. But, this patient, labrum still had good integrity, good thickness, and doing a nice osteoplasty and a nice labral repair really made a big difference for him. So he's 2 years out, and he's loving his hip. Here's his pre and post-op views. So to conclude, really know your anatomy, differentiate morphology from impingement, thorough history and physical, critical for these patients. Anytime that you have concerns about the diagnostic workup, consider other things on the differential, treat all the deformities and repair, reconstruct the labrum, and of course, watch out for dysplasia and arthritis. Thank you.
Excellent. Thank you, Guillaume. I think I echo your sentiments. I have learned a lot already, and we still have a way to go. And this has been a very successful endeavor, I would say. Again, testament to the fact that you guys have kept people entertained, because we still have 115 people listening in. So along those lines, I will tell you what I do when I see femoral acetabular impingement in adolescents. And when I began this webinar and gave the introduction, I told you just how prevalent hip dysplasia is, affecting 1 in 10 people. Well, it turns out that FAI may be just as prevalent or even more. In this study that was presented at the AAOS meeting of collegiate football players, they found that femoral acetabular impingement on radiographs was almost ubiquitous amongst these football players. And it was even more prevalent in this study presented at the annual meeting of POSNA a few years ago, but they found that basically everyone had some sign of FAI. But, and the big caveat to this is that multiple studies have shown that most of these hips do not actually develop arthritis, despite having this radiographic impingement. And we know that instability is a much stronger predictor of arthritis than idiopathic FAI. But what happens after the most common pathology in adolescents? Slipped upper femoral epiphysis. So this is the most common condition we see around the hip in adolescents. And the gold standard of treatment for stable slipped upper femoral epiphysis continues to be in situ fixation. That was shown in this long-term study from Iowa by Dr. Stuart Weinstein, who showed us that most of these patients did very well with in situ fixation. They developed very little arthritis. However, a few years ago, we actually published a paper looking at the specific incidence of arthritis when there was impingement after slipped upper femoral epiphysis, looking at the specific diagnosis of FAI after a slipped upper femoral epiphysis. And we were able to have 121 patients out of a total population of about 600 come back after having in situ fixation for a stable slipped upper femoral epiphysis at a minimum 20-year follow-up. We used a modified Harris hip score, and we called it FAI when there was pain on flexion below 90 degrees of flexion and below 15 degrees of internal rotation. Because some people would say that if the impingement sign isn't causing pain, it's because you're not doing it right, and eventually everyone gets impingement. And we used the alpha angle measurement of greater than 55. So if you had an alpha angle greater than 55 and pain on less than 90 degrees of flexion and less than 15 degrees of internal rotation, that's when we called it FAI. And we quantified the amount of osteoarthritis using the tonus classification. So what we found is that 96 of these 121 patients actually had clinically relevant and radiographic signs of femoroacetabular impingement. So it was pretty common. But how did this affect their outcome in terms of function? Well, it turns out that the Harris hip score was significantly better when they didn't have impingement. As you can see, although there was less patients without impingement, they did significantly better. And this has effects on real-world conditions. Our cohort had this interesting finding of an unemployment rate of 26%, which compared to the published national average of just over 4.6%, which is 6 times higher. Understandable, this is government numbers, but still, it was interesting that we had a high rate of unemployment, with some of these patients literally telling us that it was because of their hip that they couldn't work. So that begs the question, can we alter the natural history of FAI in adolescents? And as I mentioned, there are papers that have shown that FAI may not be as bad as we think it is. This was an interesting paper from the Mayo Clinic that showed that the natural history of FAI was actually very similar to morphologically normally shaped hips. And they concluded that the correction of FAI to a normal morphology may only minimally impact the natural history. So I like this saying, orthopedic surgery is just anatomy and common sense. And if you know where things should be, you can fix them. Can you play that video, please, Eric? You already saw this video that Dr. Yum presented to us, but if you think about the normal anatomy and what this should be, when you have a slip with this resulting big bump on the proximal metaphysis, it only makes sense to want to either realign this or trim this down so that you don't have this impingement. You want to establish a normal anatomy, restore the mechanics, and hopefully event early arthritis. So the treatment, if you base this on common sense, is to try to restore normal anatomy. We can go to the next slide. So the treatment essentially is recontouring of the femoral neck, as Guillaume just told us, and repairing the labrum when it has been torn. But the approach can be done through one of three ways. You can do a arthroscopic approach, a surgical dislocation, or a mini open, which is my preferred. I'm going to spend most of the time discussing this. However, I think it's worth bearing the concept of surgical dislocation as described by Professor Gans, which allows maximal access to the joint. Of course, this is a much more invasive procedure. It's done through a modified Gibson approach with this trochanteric flip osteotomy, preserving the vasculature of the proximal femur. But this approach is the only way you can truly have 360-degree view of the femoral head. And you can see on this image a big cam lesion on the neck, which, again, by doing a surgical dislocation, you can have access to the entire head. And you can use these really cool instruments, which are called femoral head sphericity templates, to know exactly where that bump is and not resect more than necessary, because as we've seen, overzealous resection of cam can lead to poor results. So I think that these templates actually help you to be slightly more accurate in trying to restore normal or close to normal anatomy. And you can see how you can trim this down, similar to what you saw with the arthroscopic approach, but you just get a more extensive view. Of course, this is a very large incision and not without its morbidity, but this also allows excellent access to the acetabular rim, as you can see, which allows for work on that if you do have pincer or mixed type impingement. And you can also do your labral repair through this open approach, and it allows very accurate placement of your anchors. You know how spaced out they are, and I think that it allows for repair. But as I mentioned, this is a maximally invasive procedure. Can you play that video, please, Eric? So I noticed that in slipped upper femoral epiphysis, the bump is almost always reliably in the anterior and lateral aspect of the neck. So I don't think you need to do a full surgical dislocation or a scope for most of these patients. And by using this mini open approach, this allows you enough access to the pathology. In this animation, you'll see through this 3-centimeter incision, developing a plane between the tensor fascia lata and the rectus femoris, with the sartorius more superficially. You do this L-shaped capsulotomy, protecting the lateral retinacular ascending vessels. Then you can place those stay sutures in the capsule and expose the femoral neck. And by placing a Homan retractor, one behind and one in front, you can also place one superiorly, which gives you access to the acetabular rim and allows you to work on both sides of the joint. So you can take a high-speed burr, shave down the cam lesion, performing this osteochondroplasty, get a normal contour down, and then do a same on the acetabular side. And again, you have enough access through this approach to do any labral work and place 2 or 3 suture anchors, which typically is enough for these patients. And I was surprised when Dr. Lomas mentioned 2 hours in traction, because I maybe have a little bit of ADHD. Any procedure which takes me over about an hour begins to become beyond my understanding. So I get a little frustrated, and this is a very simple approach, which is very easy to do and is very aesthetic. And if you go to the next video, please, Eric, next slide. And yeah, this video. This was recently submitted to the AAOS. And again, you'll see this small incision. This one was a little larger, but for the effects of the camera, this allowed good visualization. So you see a small incision beginning just distal to the ASIS, developing this plane while protecting the lateral femoral cutaneous nerve. So identify the sartorius superficially and expose the capsule beneath this. And these lighted retractors are very useful to illuminate the field. And what we do is we open the capsule. As you take the hip through this range of motion, you can identify exactly where that impingement is coming from, which you could see there. Then I like to use a marking pen to mark out exactly where the CAM lesion, where the extent of this is. I use a curved osteotome to take away some of this and begin the recontouring. And then I switch to a high-speed burr to shave down the sclerotic bone and achieve this more spherically shaped head. And as you can see there, you shave this down to more healthy-looking bone, and you can get a nice contour, leaving a nice junction between the head and the neck, as you can see there, and you can evaluate range of motion. It's crucial to evaluate internal rotation, as you will never get more than you have on the table from physical therapy. Again, you see closure is very simple, quick, and aesthetic. If you go to the next slide. So what are the results of this mini-open approach for FAI? This is a series of 46 hips with a mean age of 15 years, ranging from 11 to 18. Most of them were male, and most of them had had symptoms for about a year. And the mean wound size for this was 4.2 centimeters, ranging from 3 to 6.5. The mean surgical time was actually 34 minutes from incision to closure. And we looked at outcomes using this modified Harris hip score preoperatively at 6 weeks, 3, 6, 9 months, 1 and 2 years, and used the visual analog scale to determine the presence of pain. Radiographically, we measured the alpha angle. And you can see an MRI with some interference from a screw, but you can see a discrete labral tear in the anterior aspect and significant amounts of synovitis in the joint. Statistical analysis was carried out with these methods, which I would struggle to explain, but I'm told they are fantastic and they're the ones we should be using. The results, as far as pain, were very good. If this is the visual analog scale, you can see that it went from a mean of 6.6 preoperatively to less than 2 at 1 and 2 years, and this was sustained. So they maintained this significant reduction in pain. And similarly, using the Harris hip score for function, the score went from a preoperative mean of 78 to a mean of 93. And again, this was sustained over 2 years. Radiographically, the alpha angle went from a preoperative of 58 to 48 at 2-year follow-up. There were no significant complications and no major differences between the two surgeons who had been performing this, so we can conclude that the mini-open approach for FAI reliably reduced the symptoms and improved the function without significant morbidity. Now, there are some limitations. This is a relatively small study. It's non-randomized. There is no comparison group, and we'll admit we don't have validated outcome scores for this, but I will still say that mini-open is the safest and most effective way to treat FAI, specifically after a slipped upper femoral epiphysis in adolescents. And with that, I will hand it over to Dr. Roy Davidovich, who's going to tell us how we've all got it wrong, because the solution to all of this is metal on plastic. I'm just kidding, because Dr. Davidovich actually has a very significant interest in hip preservation, and I think his perspective will round out this webinar very well.
Okay, thank you. Thanks, Pablo. I know we're running short on time, so I'll make this quick. I do spend my time doing hip replacements, pelvic osteotomies, and hip arthroscopy. So I often find myself at the edges of each one of those indications and crossing over from one to the other. And as such, my indications are evolving. But in general, this is the paper from 2003 by Gons that launched many hip preservation careers, and increased the rates of hip arthroscopy over the last 2 decades. And one of the things that we have to understand is that the most commonly used grading system for arthritis today is the tonus grading system, which is from starts at 0, 1, 2, and 3. And 3 is basically bone-on-bone arthritis. And I have to tell you, this one is a grading system that really hamstrings us. As you know, insurance companies use this as a criteria for when to approve hip replacements and payment for hip replacements, with most of them demanding to see a tonus grading of 3 for hip replacements, which, as you'll see, is not always appropriate and many times actually isn't. So what are the limits of FAI surgery? We touched on hip dysplasia, and we touched on age, and we touched a little bit on arthritis. And really, after 20 years of doing FAI surgery, has the orthopedic community come up with some sort of consensus on these things? And there was a paper in 2019, which is sort of a phase 1 of an international consensus project, looking at sort of best practice guidelines for arthroscopic FAI surgery, and looking at this and looking to see if there was any mention of how to treat patients who have some arthritis and how to address patients who maybe are too old for hip arthritis, or for hip FAI surgery. What is too old? And really, there was no real consensus. The best was an 80% consensus, which stated that when chondral damage extends to central and load-bearing areas in the acetabulum with variable thickness, or when the femoral head chondral damage shows progressive defibrillation and diffuse pathology. In those cases, there's limited to no benefit to hip arthroscopy. But as you could tell, this is a very murky description of what you should be looking for. There's really no real objective information here to hang your hat on, and you're really left with your own clinical acumen. But everybody agrees, there was great consensus that tonus 3 bone-on-bone arthritis is an important poor prognostic factor. So be that as it may, I'm not sure that was helpful. I think we all realize that that's the case. So this is an example. This is a case that was referred to me. This is a 32-year-old martial arts patient. He had 2 prior hip arthroscopies in the right hip. Both of them failed. As you could tell, he had failure of resection of a very large cam lesion, and he had labral repair. He continued to have significant amount of groin pain, and on top of that, he does do martial arts, and he felt that every time he would pivot on that right leg, it would give out on him. He would feel the hip sublux out of the joint, and this is the MRI, and you could see there's subchondral cyst. There is degeneration and loss of cartilage right at the weight-bearing area. A very large cam, which you could tell somebody attempted to put a burr into somewhere over there. There's also a cyst in the femoral head. So in this 34-year-old who has what I consider significant arthritis, has a failed 2 failed FAI surgeries, a really macerated labrum. In this patient, I indicated him for a total hip replacement, and that might seem aggressive, but I don't think that there is any way that an arthritic hip such as this one, that also, if you look at the lateral view, is subluxed out of the joint with external rotation, could in any way benefit from a hip arthroscopy. That brings us to the issue of is hip arthroscopy and sort of the older patients, ages 40 or older. I think everybody on this panel is older by hip arthroscopy standards. Unfortunately, there are a number of reviews on the outcomes of these patients, and these cohorts were mentioned in 2 previous talks. And these reviews looked at outcomes, complications, and the endpoint of conversion to total hip replacement and other age-related predictors of outcome. This is another paper. It's basically the same review. It got published in 2 different journals, but a year apart. But they looked at 8 studies that commented on PRO scores, outcomes in scope patients greater than 40 years old, and there were statistically significant improvement in PRO scores in all 8 studies. And these findings were regardless of the actual indication in this patient. So this is basically, these are the studies. You can see it's not a huge number of patients. It's all level 4 evidence. And if you look at the ages, the mean ages were mostly in the 50s, some in the 60s, and pretty decent 2.5-year follow-up. And if you look at their Harris hip score at the latest follow-up at about 2.5 years, 7 out of 8 had really nice improvements in their Harris hip scores, pretty much in line with what you'd see in younger patients, with Harris hip scores coming up to the low 80s in many patients, rarely to the 90s. And these are some of the other outcome measures, all very consistent improvement in these patients above the age 40. Again, most of these studies were patients who were tonus grade 2 or lower. There were a couple of grade 3 tonus patients. 7 of the 8 studies showed improvement in a PRO score with a moderate to large effect size. And the effect size of the PRO score was really correlated to whether or not a labrum repair was performed. So labrum repair was superior to labrum debridement. The overall reoperation rate was about 20%, and if you compare that to a younger cohort, less than 35 years old, let's say, where the typical literature has quoted reoperation rates of around 5 to 8%, so definitely a higher reop rate, and conversion to total hip was about 18.5% at a mean of about a year and a half. The conversion to total hip was really correlated with the degree of the arthritis during the arthroscopy, and correlated with, interestingly enough, with lower preoperative PRO scores. And if you kind of look at age ranges, if you look at 40 to 50, there was an 18% conversion to total hips, and greater than 60, about 25% to total hips within a year and a half. So what type of hip is too arthritic for an arthroscopy or for FAI treatment? Larson looked at his series, and the failure rate in an arthritic patient was about 52% compared to 12% in the non-arthritic, and he found a greater than 50% joint space narrowing or less than 2 millimeter joint space. The failure rate was about 82%. These are really important numbers. Another study by Skenzel et al., less than 2 millimeter joint space had high rates of total hip conversion. And then the paper that's probably cited the most is Philippon series from 2012, where he looked and found age cutoff of greater than 50 and less than 2 millimeter joint space were 10 times more likely to undergo total hip replacement, and then less than 2 millimeters was really of joint space was really the most powerful predictor of arthroplasty within 2 years, and this is regardless of age. So that's an important point to make, that really arthritis, the degree of arthritis is what trumps age as far as outcomes. None of this answers what to do about very low-grade cartilage damage and a preserved joint space, which is a much more common scenario that you might see in practice. But that's something to consider. But in general, these patients will do reasonably well if the joint space is preserved. So moving on to pushing the limits, if hip dysplasia, and hip dysplasia, the limits can be pushed in 2 directions. Number one, when is there too much arthritis in the dysplasia, and should you push for a total hip? When is there just enough dysplasia to do a hip arthroscopy versus a PAO, those borderline cases? But in general, this is probably the most recent series that's been published. This was published last year by Joel Mata, and this is his own personal series of 20-year survivorship after PAOs, and we know it is a very successful procedure when appropriately indicated. And the survivorship of PAO at about 10 years for all comers is somewhere around 90%. goes down to about 70% after 15 to 20 years. But if you broke down this pretty large series based on age ranges, PAOs done at age 20 versus 30, 40, and onward were the ones that tended to survive longer, and that undoubtedly has to do with the health of the cartilage during the PAO. If you look at the tonus grading in these patients, obviously tonus of grade of 2 performed quite poorly with a PAO, although up to 10 years with decent outcomes. And these numbers really line up with previous series in the literature of pelvic acetabular osteotomies for hip dysplasia, with a survivorship of somewhere between 80 to 90% at about 10 to 15 years. Now, interestingly enough, and something really important to keep in mind, that there's been many series of total hip replacements in patients who are young. One series in particular, which was a decently coordinated study, looked at total hip replacement in patients less than 35 years old, and 87% had a 10-year survival rate with 55% 20-year survival rate. So keep that in mind, because that really falls in line with what our PAO numbers are showing, and that has to do with the expertise of the surgeon for sure. And really, the holy grail is the 100-year hip. So I believe that as soon as there is a poly that doesn't wear, then perhaps total hip replacement will obviate the need for any osteotomies, even though it's a fun operation to do. We touched on lateral center edge angle, and this is often cited as the criteria for deciding on the degree of hip dysplasia, but this is really not enough to go on. As Pablo mentioned, there's really more that goes into deciding which hips are dysplastic. And if you really look carefully, about 10% of hips will have some sign of dysplasia, whether it's the center edge, the tonus angle, the depth, etc. Just to go back one slide, the question is, I mentioned pushing the limits of PAO, but in my mind, pushing the limits of PAO is taking a patient that has perhaps a lateral center edge angle of 25 and a tonus angle of approximately 13, so very much borderline, and taking that patient and doing a PAO on that patient as opposed to hip arthroscopy. And really, this depends on patient's age, their cartilage status, and the degree of instability. And instability is something that you can really only truly assess by listening to the patient and performing a very careful exam. I use sometimes in patients a live fluoroscopy exam or an ultrasound exam, but I rely on apprehension sign and on physical exam, looking for increased pain with an out-toed gait or decreased pain with an in-toeing gait, which indicates to me that the patient is trying to stabilize their hip. But in general, these patients will describe to you that the hip is sort of sliding out of the socket, or they'll describe that they walk down the street and suddenly their hip gives way on them. I mean, if you listen to them carefully, they will actually describe the sense of instability. This is a patient. This is when I saw her, an Olympic fencer. She came to me after she underwent 2 hip arthroscopies. The X-ray on the left, the AP pelvis, is prior to her first hip arthroscopy. She had a center edge angle of 24.5 and a tonus angle of about 13. I like to measure them on a 3D CT scan with a line lined up with the anterior and inferior iliac spine. She had about a 22 degree lateral center edge angle, but if you look at her femoral head anteriorly, it's almost completely uncovered, and this was her leading leg when she was fencing, and she would keep feeling that the hip would slip out. She had 2 hip arthroscopies by 2 different surgeons. She kept feeling the hip slip out. She never really did well, and she presented to me with a completely trashed hip, and at age 24, underwent a total hip replacement, and her fencing career, unfortunately, is done. This is another patient, very similar findings on X-ray. Really very mild dysplasia, very, very mild, and minimal to no arthritis, really. She underwent a hip arthroscopy, which failed. She came to me, and her main complaint was that she kept feeling her hip slip out. It keeps slipping out. And, I took a quick glance at her med list to make sure to look for any psych meds. There were none. And I'm not speaking facetiously. You do need to look at the number of psych meds that some patients are on, especially there have been plenty of studies in hip dysplasia patients and their ability to cope with surgery and their condition. But in this patient, you could see she had a very shallow anterior wall. And the caveat on this patient is, even though she doesn't have much arthritis, she is 60 years old. And she had hip instability. And on this patient, I elected to proceed with a total hip replacement to give her stability, which is, think about that. That's something we historically don't associate hip replacements with increasing stability. But in this patient, it was exactly what did the trick. I only gave her 15 degrees of anaversion to decrease her natural anaversion that she had and used the dual mobility component. She did quite well. Another patient with relatively mild dysplasia, also with instability, sensation in the hip, feeling that the hip kind of slips out or slips laterally, with significant amount of pain, an MRI with a really clear cartilage surface. And on this patient, to me, it's a no-brainer. This one gets a pelvic osteotomy. She had a labral tear, but her sense of instability and not just pain is what pushes me over the edge to avoid an arthroscopy, and she underwent this correction and did quite well. I thank you for listening to me. I know we're kind of running late, and I'll hand this back to Pablo for any questions.
Thank you, Roy. Yeah, we're right on time right now. We're actually exactly at 90 minutes right now, which was the assigned time. But I do want to thank everyone for participating once again. And if we do have any questions, we can certainly stay on for a little bit longer and answer these questions. But I want to be mindful of everyone's time and get you back to your normal life. There is an interesting question that came up a couple of times about the role of femoral derotational osteotomy in the setting of FAI. Dr. LaTrenta, what do you think about this? This is, when we talk about derotating the femur, it tends to be a subtle correction. You're not talking about 30 degrees of correction. And is it worth the, do you get the bang for the buck for doing a derotational femoral osteotomy? And can you accurately correct these relatively subtle rotational issues in the setting of FAI?
Yeah, I definitely think that's challenging. I was sort of reading the chat a little bit as the talks were going on, and I think Dr. Davidovich had mentioned the answer was a retroverted femoral neck is maybe more likely to impinge. So I think that you can kind of look at the version and correct it. I feel like we talk a lot about like the dysplastic population having a more like anaverted, femoral neck. And I think another thing that's sort of challenging about it that you and I have talked about is if you correct a very small amount of version, does that patient, what do they do differently with their foot? And how much do we really get? So I think that at least I don't have experience with it. I know that some other people have done derotational osteotomies, especially maybe if they've done a surgery and seen it fail, or had someone that had a reason to look for something other than just correcting the problem, with the scope. But I think it's very very challenging to define what you might get after doing a femoral osteotomy.
Great, Roy. What do you think? Does it muck it up for you? when someone tries to go in and does a derotational osteotomy to get, say, 12 degrees of derotation? Does that make your total hip different?
Well, it doesn't really. I mean, except for taking out the nail that's in there. But yeah, that gets in the way. But the thing you have to be careful about with the derotational osteotomy is you really could change the foot progression angle of the patient. It can make them quite unhappy. So I try to really avoid doing a derotational osteotomy when possible. The same when I do a total hip. I focus more on the acetabular side as far as obtaining stability for these patients.
Great, yeah. So we'll conclude, I think, we're a little bit over time, and I think we've had some very good discussion. I want to thank all of the faculty one last time and conclude this will be recorded and will remain as enduring content on the NYU website. So once again, thanks to everyone for attending. The CME credit instructions can be downloaded if you click on the link which is in the middle of your screen. And thanks to everyone and have a good night. Thanks, everyone.
On behalf of NYU Grossman School of Medicine, I would like to thank you for your participation in this course. You will now be redirected to the CME login page. Please log in to complete the course evaluation and obtain your certificate. This concludes today's program. Thank you and have a great evening.